Good morning. Thank you very much, Dr. Grant, for the invitation. And I want to thank ASA, the organization, the wonderful Ms. Patrice, and the President, Eric, for everything they've done. So thank you very much for the invitation. It's been a privilege indeed. So I'm going to talk about a common, I think, autonomic issue that we see in the autonomic clinic, but also I think it's very relevant to Chiari patients. And that's the topic of orthostatic dizziness and orthostatic intolerance in general. So a little bit about the autonomic nervous system, and I apologize if I insult anybody's intelligence in this audience. Many of you are incredibly educated, but I thought maybe I should start a little bit from scratch. So this is the part of the nervous system that's responsible for your homeostasis. Homeostasis is a word that basically means your inner balance or inner equilibrium, And we basically, in neurology, we think of it in two different components, like everything else in neurology. There is a central component and a peripheral component. But also when we approach the patients in the clinic or when we do research, we also tend to think in terms of organ specificity. What part of the organ that's mostly symptomatic? Is it something with your heart or your blood pressure? Is it your sweat function? Is it your pupillary function? Is it your digestive system, GI? Or is it actually your bladder function and your sexual function? So these are all things that we think about. In terms of anatomy and pharmacology, and that can be an entirely different topic by itself, but it's simple to keep it into three different components, which was really originally described by the pioneering physiologist. You've got a parasympathetic component, which is basically the rest and digest. And the main neurotransmitter is a chemical component called acetylcholine. The second component is the sympathetic system. That's your fight, fright, or flight system. And for the most part, it uses your adrenaline and noradrenaline, or epinephrine, norepinephrine. In some situations, it also uses acetylcholine. And the third component is your gut, your digestive system, which actually has its own neural network. It has its own brain, but also talks back and forth to the autonomic nervous system and is important for that function. If you look at the most common symptoms of orthostatic intolerance in any dysautonomia program, this happened to be in Vanderbilt, you will notice actually that many of the symptoms are in the form of lightheadedness, dizziness, exercise intolerance, fatigue and blurred vision. So a large majority of patients have that. Chest discomfort in about 2/3 of the patients. Sometimes these patients go to the ER thinking they have a heart attack. Palpitations, near syncope or near fainting. You have a variety of other symptoms. So these are very, very common symptoms of orthostatic intolerance in patients with dysautonomia. Well, what's relevant actually to some degree is with Chiari. So this was one of the papers by Professor Milorad looking at Chiari type 1 patients, is that I put the list that he had in about 364 patients with Chiari 1. And I put an arrow for you for the symptoms that could potentially overlap with autonomic dysfunction. Now you may say, well, dysphagia really is not autonomic, which is true. Dysphagia is really a bulbar symptoms, but it implies involvement of the vagus nerve, and the vagus nerve is part of the rest and digest. So patients with dysphagia, with Chiari malformation, or dysphagia with any autonomic dysfunction, you can always, when you test them, you will find vagus nerve impairment. So there is some autonomic dysfunction as well. Sleep apnea, both actually obstructive as well as central, is actually an autonomic phenomenon. Hoarseness, same thing, vagus nerve impairment. Palpitations, very, very common. And then syncope. So you see there is some overlap, quite a bit of overlap actually, between patients with Chiari 1 malformation and patients who are seen for autonomic dysfunction. So I'm going to focus today on the main conditions of orthostatic dizziness. When somebody comes to see you in the clinic, and they are referred to us for postural dizziness, with or without syncope or pre-syncope, we tend to think of three big categories. Is there a problem with the blood pressure when they are standing, i.e. orthostatic hypotension? Is there a mismatch in their heart rate and blood pressure circulation, which means excessive tachycardia, known as postural orthostatic tachycardia syndrome? I'm going to refer to it as POTS, just for abbreviation. Or is it some other orthostatic problem? Patients with Chiari, Chiari 1, Chiari 2, Chiari with Syringomyelia, etc. They have usually some compromise of their vestibulocerebellar connections and communication. So that actually can play an additional role in addition to the autonomic dysfunction. And this is something to keep in the back of our mind when we deal with these patients. What is the definition of orthostatic hypotension? This is accepted by everybody. Basically, it's a sustained drop. Sustained usually is 3 to 5 minutes, if you want to know about it, by more than 20 millimeter of systolic blood pressure or diastolic blood pressure by more than 10 millimeter within 3 minutes of standing. If you have a baseline of hypertension, the criteria is a little bit loose, and we allow 30 millimeter of drop before we diagnose you with orthostatic hypotension. It's actually a common condition because about up to 10% of middle-aged people have it. And actually, it's a condition that increases as we get older. You know, there is a greater incidence of hypotension as we get older. What are the symptoms? Well, they are all really reflection of decreased blood flow to the upper part of your body. So you will get lightheaded when you stand. It's the most common presentation. If the drop is very steep, you can actually pass out. You will have fainting or near fainting. There are some triggers for patients who are prone to orthostatic hypotension. Prolonged bed rest. You know, you've had surgery and you'll be laying in bed for a while, particularly with medications on board. You're going to relax your blood vessels. You're very likely to drop your blood pressure. Large meal, like the wonderful dinner we had yesterday, you know. So alcohol consumption, fever, heat, infection actually, particularly with fever, can be a problem. And certain medications, you know, and then surgery, particularly if there is some loss of blood in the surgery. But turned out actually, patients who have very insidious chronic orthostatic hypotension have sometimes other symptoms. They may feel a little bit lightheaded or dizzy, but they are actually more likely to report dizziness and imbalance than lightheadedness. So if someone is very, very dizzy, you know, take your blood pressure. Fatigue can be an issue. They can feel, and they can sometimes fall. Some of our patients with autonomic dysfunction that's chronic, they will have frequent falls. And then when we take their blood pressure, they're dropping 50, 60, 70 points, and they're totally unaware of it. And that's when they fall. You can have difficulties with concentration. Brain fog is a common symptom in patients with orthostatic intolerance. Sometimes patients will have reduced blood flow to their trapezius muscle, upper shoulder and neck. So they complain of this coat hanger type of a pain rather than really lightheadedness. You heard yesterday, for those of you who were in the lectures yesterday, there was a presentation by Dr. Gray, for instance, that can be a symptoms in leak, right? You know, so there is some overlap with leak as well. Chest pain, dyspnea, palpitations. And another thing that can overlap with leak is orthostatic headaches. So if somebody have a headache when they stand up, they could have a CSF leak, but they could also have chronic orthostatic hypotension. So this is something to think about. Why does this happen? Well, when you stand up, there is a shift of a certain amount of blood, about 500, 600 cc's or so, that goes down immediately into your lower body. Roughly think of it below your sternum or below your belly button. And as a result, you dilate your blood vessels because it has to accommodate for this blood. Well, two things happen. You need to first counteract that to keep the blood pumping up. So you need some vasoconstriction. But your heart accelerates a little bit to make up for the fact that the blood is now fleeing down to the periphery. So you get a combination of slight drop or balancing of your blood pressure and slight increase in your heart rate. And this is all mediated by a complex network in the autonomic nervous system known as baroreflex circuitry, baro as in pressure circuitry. So when you stand up, 500 cc will shift, and then there will also be an additional shift of plasma, 10 to 25% of plasma volume will shift. And that's actually important to remember when you have chronic orthostatic hypotension. If you have an acute or subacute orthostatic hypotension, your fluid shift recuperates in the same day or 2 days. But if you've had chronic orthostatic hypotension, this plasma leakage becomes a little bit more chronic, and that actually adds a little bit to the issues of autonomic or orthostatic intolerance. If you are a normal person and you stand up, or if we strap you like Frankenstein to a tilt table and flip you up, what happens? Well, what happens is you increase your heart rate roughly by about 10 beats, but your systolic blood pressure actually should not change if you're totally healthy. and you may have a slight increase in your diastolic blood pressure, which is the lower value, by about 5 millimeters. So that's really what should happen. Now, I mentioned that this communication back and forth between the forces that dilate and constrict your blood vessels and the forces that control your heart rate is mediated by complex circuitry known as the baroreflex. And the baroreflex, basically, these are baroreceptors, pressure sensors that are in your carotid artery, aortic artery. And they talk back and forth to your heart, to your brainstem centers, the vagus nerve, to your sympathetic chain down in your spinal cord, and they regulate that circuitry. And I won't go through this because it can actually be a lecture by itself. But I wanted to show you the location of this reflex, and I wanted to superimpose on it where Chiari pathology with or without syrinx is. So if you look at that, now you can imagine why this potentially could be affected in patients with Chiari, particularly if they have syrinx. There is a compromise in this protective loop, which can delay sometimes the formation of their reflexes and how they respond. There are various types of orthostatic hypotension, this is a good slide, I think, to show you that was taken from good work in the American Autonomic Society. And an uncommon condition which we tend to see in adolescents, usually, is that when they stand up, they drop their blood pressure quickly, but they recover within 20 to 30 seconds. And that's called initial orthostatic hypotension. It's usually fairly benign and it's transient, but some kids become pretty symptomatic with it, and they are almost always an adolescent kind of a patient. And we see it occasionally in Chiari patients. But probably the more common ones are those two types of orthostatic hypotension. So these curves, the top burgundy is your high blood pressure, systolic blood pressure reading. The purple is your diastolic blood pressure, and the green is your heart rate. So this is in all curves. So in this one, you see there is a drop, sustained drop in the systolic blood pressure, not much in the diastolic in this one. And there is a commensurate increase in heart rate, versus in this one, you have a steep drop in the blood pressure with little change in the heart rate. So when the heart rate increases to match the drop in the blood pressure, that's called non-neurogenic orthostatic hypotension. When the increase in the heart rate is too weak to match the drop in the blood pressure, that's considered neurogenic orthostatic hypotension. Why is that important? It's important because neurogenic orthostatic hypotension almost always indicate dysautonomia. If you see it in somebody in the clinic, you don't have to be a great scientist. You can conclude they have dysautonomia, and they probably should be evaluated for dysautonomia because it's actually less benign or more malignant form of orthostatic hypotension. But some patients don't drop their blood pressure in the first 3 or 5 minutes. And those are the patients actually who have what we call delayed orthostatic hypotension. And those patients typically present with the following story. I feel fine. I go to the grocery store, but then I have to wait in line at Costco. And then I start feeling my legs getting weak. Or I go with my spouse for a hike or a walk, and I do very, very well the first mile and a half. Then I get so weak and so fatigued in my legs, I have to sit down. And those are patients actually, if you only stand them up for the 3 minutes in the clinic, which what we usually do in the autonomic clinic, or if you tilt them for up to 10 minutes, sometimes you miss the orthostatic hypotension. They have a condition known as delayed orthostatic hypotension, and actually this is also a form of autonomic disorder. Some patients drop the blood pressure before they faint, but some actually faint without dropping the blood pressure. There are various types of syncope. And also, some patients have this entity where actually the blood pressure stays the same or slightly goes up, but the heart rate jumps up by more than 30 beats per minute. And that's a condition that's called postural orthostatic tachycardia syndrome, or POTS. Okay. So what's the diagnostic criteria? It was mentioned briefly, I think, yesterday by one of the speakers. Basically, you get lightheadedness, palpitations. I think Dr. Martin mentioned it. You have lots of various symptoms, and it's commensurate with increase in the heart rate by more than 30 beats per minute, but that's in adults. In children and adolescents, we allow up to 40 beats because based on data in healthy adolescents tend to accelerate their heart more than adults. Or if you have a sustained heart rate increase by more than 120 beats per minute. Both of those are POTS. Usually in the first 10 minutes of standing, and very important, there should be no hypotension. If there is hypotension, the hypotension is the chicken and the tachycardia is the egg. Okay, so it's very, very important to think of that this way. But what's interesting about, and I always find this fascinating, I've been doing this for decades. It's like if you look at the symptoms of patients with POTS, they mimic the symptoms of patients with orthostatic hypotension, right? Many of them do, they overlap. Yet there is no orthostatic hypotension. So why is it that when your heart rate accelerates quite a bit, but your blood pressure doesn't change, you have the same symptoms almost as if your blood pressure had dropped? So very, very interesting. That's again an area of research we're looking at. So these are the two major types of POTS. This one, you've got the red is the systolic blood pressure. The green is the heart rate. Those are from our autonomic lab at Stanford. You see the blood pressure standing steady. The green arrow is when we tilted the patient. And there is a dramatic increase in the blood heart rate by more than 30 beats. In this particular one, there is a sustained heart rate exceeding 120 beats per minute for the entire duration of tilt. So these are the two forms of POTS. It's important that the symptoms improve when the patient sits down or lays down. That's very, very important. And usually we like, before we really consider this as a condition that needs to be evaluated and treated, you need the symptoms to be present for about 6 months. Because many cases, like some of the Chiari you've seen, sometimes resolve spontaneously. So there is really no need to concern the patient or worry too much about it. And then you want to rule out other causes that, that are obvious, precipitating. What is not POTS? And I want to mention that because sometimes we get referral to us for POTS, but when I look at the chart, it's like, well, this is really not POTS. So what is not POTS is when the tachycardia is present when you're sitting or supine. You can have inappropriate sinus tachycardia, and that is really not POTS. When you stand up, your heart rate is going to accelerate further, and you may exceed 120 beats per minute. But if your supine heart rate is 110 beats per minute, this is not POTS, right? You have a different reason. If the symptoms are not relieved, at least by 50% when supine, or if the tachycardia is very, very brief, it lasts a minute or two, you probably have early orthostatic hypotension. Or some patients actually, when they stand up, they tell you, oh, I'm not dizzy, just the room is spinning. The room is spinning and so on. That's called orthostatic vertigo. It could have a blood pressure component, but that usually indicates a vestibular problem. By the way, orthostatic vertigo can happen in Chiari patient, particularly after a concussion in our experience. POTS is quite common, up to 1% of the population. Syncope is very common, up to 4% of the population. And it's mostly, the POTS is a young people disorder, 15, maybe I would say up to 40 years of age. The women are much more affected than men. The ratio is about 4-1. That's constant in every autonomic center. There is a prevalence among Caucasian. And we talked a lot yesterday, there was a lot of talk about hypermobility and Ehlers-Danlos syndrome. There is actually a predisposition to POTS in these patients. Preceding infection is very common, mostly viral. We have young folks who've never had any health issues, but then they get their mononucleosis, and then boom, now they have POTS. They get gastroenteritis, boom, they have POTS. And we're seeing a surge in POTS, actually. We have a study going on after COVID. So COVID has been now a main reason for POTS since the coronavirus epidemic or pandemic. Surgery sometimes precedes POTS. Patients will have no problem. They have a surgery, any kind, and then they have POTS. Significant concussion and head injury, and that's we've seen in Chiari patients, particularly prone to that. Some patients develop POTS when they are going through puberty, and then 5-6 years later, everything stabilizes and they no longer have POTS. Toxic stress, kids growing in families where there is lots of conflict, etc. Sometimes they develop POTS. And we always check ferritin, iron reserve, ferritin, and vitamin D in these patients. About 40% of them have low iron or vitamin D. And actually, if you correct it, you improve the symptoms of POTS. And finally, we always check to see, do they have thyroid or adrenal issues? And some young women have basically exacerbation of their POTS, particularly if there is a migraine during the time of their cycle. So this is something to think about. In the clinical evaluation, we like to look and see what type of a color the feet turn to when they are standing up or sitting down. So they have a tendency to pooling of the blood in their feet and legs, and they can really see them in the clinic. It turns red, sometimes it turns purplish, but then you have them lay down and the color improves. And that tells you there is a significant amount of vasodilation in these patients. Also, you saw yesterday's slides about the hypermobility. We always check these patients for hypermobility because Ehlers-Danlos is a common condition in these patients. You saw that yesterday, so I will skip that. So, and again, there was a whole talk about it yesterday on all these heritable connective tissue disease, but I just put this for you today as a reminder. I don't need to go through it. But when you have an overlap with EDS, that makes you predisposed to POTS. So, and Dr. Martin showed yesterday a slightly similar slide to this. It shows you the overlap with other conditions, chronic fatigue syndrome, fibromyalgia, autoimmune syndrome, etc. And I added this little bubble here of Chiari 1. Because actually there is an overlap, Chiari 1 hypermobility, and those patients are actually very likely to develop POTS. So, like I said, it's a mystery why these patients will have symptoms of cerebral hypoperfusion, even though their blood pressure is fine. But they also have symptoms of sympathetic fight or flight, overactivity. So they feel palpitations, chest pain, tremulousness. About 1 in 4 patients with POTS who come to see us in the clinic have had the diagnosis of generalized anxiety disorder, So that tells you how common it is. But when we examine them and we find that they have POTS and we start managing it, the anxiety disappears. So it really is not the anxiety, it was the POTS all along. And then many of these patients will feel presyncopal, but syncope is not as common as it is in orthostatic hypotension. Pathophysiology multifactorial, and I'm going to go through a few things. So there is usually a component of volume depletion, a component of decondition. I'm going to talk about the nerve or neurologic contribution to POTS, and finally this entity known as hyperadrenergic POTS. So first, what happened with volume depletion? So studies that looked at and evaluated patients with plasma volume, red cell count, and total blood volume. If you evaluate patients with POTS compared to the control, age-matched control and gender control, there is almost a volume deficit of about 350 cc's. And some of that is, if you remember one of the earlier slides, I told you there is a plasma leakage, right? And that usually is reversible, but if the condition is very chronic, plasma leakage becomes somewhat less reversible. And that explains why you have that problem. So these patients walk around, even though they think they are hydrating or hydrated, they are actually about 350 cc's short of fluid. So there is this problem. Another clue that came was basically studies at NASA that looked at astronauts. When they go up to 0G and then they come back. I don't know if you've seen those movies. They always, they have these people who are incredibly fit, right? Astronauts are very fit. But when they come back from their space missions, they have people holding them. Otherwise, they're going to collapse, coming down on the tarmac. And when people ask, well, why do they collapse? Well, they thought it's going to be their blood pressure, but actually it was their heart rate. Their heart rate was remarkably high. And as you see here, and it's commensurate with how long they stay in space. But when they come back to the landing day, there is a dramatic increase in their heart rate. And some of the astronauts almost pass out as they are coming. So, you should put them on and they wheel them out, So the idea came, there may be some deconditioning because that's the only thing that could happen to the heart when you're out without gravity. You decondition the heart and you reduce the size of the heart. And that came up with the concept of the so-called small heart or the Grinch heart syndrome. The Grinch heart became politically somewhat not favorable, so they took it out. So now it's called, again, small heart syndrome, right? So, but basically your cavity, actually, if you do the echocardiogram on these patients over time, the ventricular size is a little bit decreased, as if they were deconditioned out and, with no gravity. But there is a variant where those patients will increase the heart rate and they have this fight or flight response. And if you measure these patients' adrenaline, and particularly noradrenaline, it is pretty high. And that's called hyperadrenergic POTS. And those patients not only have POTS, but when you tilt them, not only they maintain their blood pressure, actually they become overtly hypertensive. So they have a combination of high blood pressure and high heart rate. And because of this constant increase in their adrenaline, those patients actually develop secondary anxiety. Okay, and then they also develop other symptoms. They have excessive sweating. It starts usually in the palms and feet, but sometimes it can be generalized. Sometimes it happens at night, and then they have tremor. We all have physiologic tremor, but now they have too much adrenaline in their system, so they have hand tremor. And then they also have fragmented sleep because of their difficulties. This is an example of hyperadrenergic POTS. Red is the blood pressure, and you see, and actually we see not only it increases, it oscillates dramatically when you do an arterial line kind of reading, and then the heart rate really increases. And if you take their adrenaline before and after you stand them up, there is a dramatic increase in their adrenaline. And some of those patients, actually, their heart rate increase is so significant that they start literally throwing arrhythmia. These little green bars here show you that this is extra beats, premature atrial contraction, and some of those patients actually get referred to us from cardiology because of that. Some patients have that in their family. There is a specific gene defect called norepinephrine transporter deficiency. It's not very common. You heard yesterday a lot about mast cell activation, so I'm not going to bore you with this. But these patients are prone to mast cell activation. And the reason for that is sympathetic activity increases, the release of norepinephrine, epinephrine, and neuropeptide Y. And that can challenges mast cell, which degranulates, and then they release histamine and some other stuff. And those patients will have lots of flushing, lots of tachycardia, and they end up actually chronically developing some allergies they've never had before, like Dr. Matalin showed up. And we usually, some of these patients refer to us for hyperadrenergic POTS. We usually evaluate their transmitters after the tilt, but also we do urinary histamine and other things for mast cells. So that was, I think, discussed yesterday. Neuropathic POTS is another big category. It is really a post-infectious condition. And those patients present with POTS, but they usually have what we call POTS plus. And the most common plus they have is GI symptoms. So those are the patients who have POTS, but now all of a sudden they have irritable bowel syndrome after they've had their mono. They've had constipation, or diarrhea, or always bloated, always nauseous, and they've never had this problem before. That's actually a neuropathic POTS. And when we test these patients, not only they have POTS, but you can measure sometimes baroreflex function will be abnormal, and then we have a deep breathing test on them that shows that vagus nerve function is not working very well. If you do a very detailed neurologic examination on them, they almost always show mild degree of peripheral neuropathy, usually involving the so-called small nerve fibers, so they have decreased pinprick in the feet. And we have a technique now where we can measure the small nerve fiber function. So one is we do that in the autonomic lab. We can measure your sweat responses. So we can put a small capsule on your foot, leg, thigh, and forearm. And in the capsule, we put acetylcholine, which is the neurotransmitter for the sweat. We ionophorese it with a small current, and that should trigger a sweat response because it goes down to the nerves innervating the sweat gland and gives you a sweat response, which you can record as basically a small nerve fiber function. And in patients with neuropathic POTS, you have that pattern. The foot will be flat, the leg will be very small, the proximal leg better, and the forearm is very, very robust. So they have this pattern where the distal body part is affected, and the so-called neuropathic POTS. And that's usually is an autonomic disorder. And you can do the skin biopsy. The skin actually is very, very nice. We can take 3 millimeter disc from your skin and look to see what happens to the nerve ending in your skin. These are, with a special stain, you can see how the nerve fibers are very nicely in the outer layer of the skin, epidermis. And patients with neuropathic POTS will have anywhere from paucity of fibers to complete loss of fibers. And that usually tells you that they've had really a neurologic condition causing their POTS. There is a frequent association with lupus and other autoimmune disease, and about 10% of patients have a special antibody that goes and jams the signaling in the autonomic ganglia. It's called ganglionic antibody. So some cases of POTS, particularly neuropathic POTS, are autoimmune. How do we manage orthostatic dizziness? We always start with non-pharmacologic measures, particularly if the impairment is somewhat mild, right? So you should try these in everybody. And then the advantage of them is that if they work, you've avoided pharmacology and all potential issues. But sometimes you have to go to pharmacology and then see what happens. So in conservative treatment, first you want to expand the plasma. Remember, there is about 350 to 400 cc shortage of plasma. So you want to expand the plasma. And the best way to do that is if you can manage oral route, right? So you want to have about, you want to have 2 to 3 liters of fluid per day. And you will have to increase your salt intake to about 6 to 10 grams. A teaspoon is 2 grams. A heaping teaspoon is 2 grams, just to give you some idea. So you want that amount of salt to do this. Some people don't like that taste of salt. So you can actually, we can prescribe you salt supplement, or you can find them, called buffered salt, and you can take that to achieve that amount. And you basically swallow it. You don't have to deal with the salt. But some people like salt, crave salt, and that actually is perfect. And then you want to try to reduce the amount of pooling of the blood in your lower half of the body. And you do this by compression stockings. And people ask always, how far up do they come? Do they come to my knees? Do they come to my thighs? Do they come to my waist? And the rule of thumb I usually tell my patients is, the higher you can take them, the better. And then you can use them a lower pressure. So if you can take it up all the way to your abdomen, you don't need as much pressure, right? 15 millimeter is fine. But if you really cannot tolerate that, you can then use them up to your knees, but then you need a much higher pressure, which means they will be tighter. So it can be a little bit tougher to put them on and take them off. Or you can mix and match. You can do a compression stocking up to the knee, and then you can do an abdominal binder by about 20 millimeter. So you can, walk with both, and that actually can help. But that actually works, and it's very effective in many, many patients. There are some physical counter maneuvers, So if I'm a speaker with a orthostatic hypotension, I would have asked the ASAP organizing committee to get me a footstool like that. And if you put your foot actually on one stool, you raise your blood pressure by about 10 to 15 millimeters. So they can actually avert some of that hypotension. You can cross your legs, or I usually tell my patient every now and then, pump your feet up a little bit, and actually you'll be impressed by how quickly that works. You can sometimes kneel on one knee and stand up, but the top 4 pictures probably are very, very good and very effective. Now, how about medications? Well, the medications we use for orthostatic hypotension have some overlap with POTS. So sometimes patients, either for whatever reason, if they have GI problem, they can't increase their fluid intake and salt, or they take it, but it's not working very well. You want to force an expansion of their plasma. And one drug we give for that is called fludrocortisone. So it's a mineralocorticoid that talks to your kidney and encourages your kidney to retain salt and fluid. And that's how the medication works. Very well tolerated in most patients, and it's long-acting, so you only need to take it once during the daytime. So that's a very, very good medication. There is a drug called midodrine, which constricts your blood vessels. So it forces the blood back up to your upper body, and it works very, very well, and it comes in various dosages. It has a short duration of action, about 4 hours or so, but has the advantage of working very quickly, within basically 20 to 30 minutes of taking it. So that's what sometimes a medication I give to my patients who don't have symptoms unless they have something situational. Some patients don't have the symptoms of POTS or hypotension unless they go to the gym, exercise, or go hiking. I would say, okay, take it right before you go at that time. Some patients, particularly if they have GI symptoms, their autonomic connection between the central and the peripheral nervous parts is sluggish. And there is a medication called pyridostigmine, which allows this communication to be enhanced. And that sometimes works very, very well. So those patients, their POTS and orthostatic hypotension get better, and their stomach motility gets better. Sometimes that's enough to treat their constipation. They don't need another medication for that. And finally, some patients, particularly if they have neurogenic orthostatic hypotension, that's dysautonomic. It means they don't make enough neurotransmitter. You have to give them the neurotransmitter. And there is a drug called droxidopa, which literally think of it as I'm giving you norepinephrine in a pill. That's how you want to think about it. So actually you're replenishing their neurotransmitter. I thought I'll talk a little bit about POTS in Chiari, since we're in a Chiari symposium. Migraine and headaches are frequently associated with POTS, and we've heard a lot yesterday about headache and Chiari. It really can be a challenge sometimes. And we work a lot with neurosurgery colleagues and neuroradiology colleagues in trying to figure out, is the orthostatic headache from leak? Is it from orthostatic hypotension? And sometimes it's a little bit of both. There was a lot of talk about cough headache, which is very, very important in Chiari. But cough syncope is also important in Chiari, and this is something really to think about. These are pretty relevant things. POTS treatment follows essentially the same guidelines for the most part. You want to expand the plasma volume, and remember there is deconditioning. So you want to exercise to build up your heart size. So exercise becomes very, very important. Compression stockings and midodrine to constrict the blood vessels. But some patients still need something to slow down their heart. And basically, we give them things like beta blockers, particularly if they have migraine, because they help migraine. Some patients cannot tolerate beta blocker, either because they have Raynaud, discoloration in their hands, or because they have like bad asthma and they cannot tolerate beta blocker. So we give them calcium channel blocker. And finally, there is a new drug that's given usually for cardiac arrhythmia, but we give it to patients who have rapid heart rate at rest that increases when they stand up. It's called ivabradine. And that's kind of more of a newer drug that was recently approved. So what happens to POTS? It's not all doom and gloom. I'm always optimistic. I always try to portray a positive picture for my patients. And I tell them, so the only really survey we have was conducted by phone at the Mayo Clinic, where they contacted 502 patients. The response rate wasn't great. Only about a third replied, but that still came up to about 172 patients. And about 70% of the patient consider their health is good. But as you see, about half of the patient will still have some persistent symptoms. So POTS is really something to tackle in a very, very thoughtful way and kind of require sometimes patients monitoring and see how you do. And with this, thank you very much, and I apologize if I exceeded my time.